Pat Allen is the head of the Oregon Health Authority, and I think well regarded by the private sector, the public sector, Democrat and Republican, folks inside the agency and outside as a steadying hand at that agency that has faced some turmoil in recent years, building on, I think, a successful track record in his role at DCBS. And so in a time of political polarization and some anxiety about the future, I think his is a steady, visionary, forward-looking voice. We're really honored that he has been with us all day and is now coming to the stage. So let's give him a round of applause. Director Pat Allen. Thanks, sir.
Well, thanks, DJ, for having me here this afternoon for that gracious introduction. I know you've all been through a full day of panels and speeches from regional and national experts who've been sharing their wisdom of often decades of experience. This will not be that. But I have come to the job with, as DJ says, about 6 years of experience regulating commercial insurance. A couple of years, DCBS received the remains of Cover Oregon and operates today the state's health insurance marketplace. But it's been a big learning curve for me in the past year. I've had the opportunity to spend time learning about harmful algae blooms, measles, meningitis, risk-based capitation payments, and rabid bats, among other things. And I've learned a little bit of health policy along the way too. So today what I want to do is talk about the next chapter in Oregon's healthcare transformation story, where we've been, where we're going, and what it means for you. The bottom line is this: Oregon's innovative healthcare reforms are working, but we face some sizable challenges. Every one of us in this room, whether you're a patient, a provider, a payer, or a policymaker, all have a stake in sustaining Oregon's successes. Healthcare transformation isn't just OHA's story, it's yours as well. Let me start by talking about the work we're doing to improve OHA's ability to support healthcare transformation. Our mission can be summed up in one sentence: to achieve better health, better care, and reduce costs. Yet when Governor Brown appointed me to head the Health Authority a year ago, we were, as an agency, in some fairly rough water. The agency was under scrutiny for Medicaid overpayments, we'd lost stakeholder trust, and the agency suffered pretty low morale. The governor charged me with 3 priorities: transparency, accountability, and the wise use of public resources. In this past year, I think we've made a lot of progress on all 3 fronts. Let me talk about that for just a minute. We're being more transparent about our decisions and our operations, our successes and our shortcomings. We've asked independent experts to review how we set rates for coordinated care organizations. We've put public records requests that we receive from the media and the responses to those requests online. And my calendar is up on our website for anyone to see at any given time. We've made OHA more accountable by reorganizing key parts of the agency so we can do a better job of focusing on Medicaid and on behavioral health. And so those programs are less fragmented, more effective, and more accountable to the consumers and stakeholders they serve. I held office hours, kind of like back when we were in college, so that staff can simply come and drop by and talk to me about things that are on their mind, concerns, ideas they have for improvements, things they think that I should be working on. And we're building a culture of business rigor to prevent those operational mistakes from occurring in the first place. We're keeping a close eye on how we manage our budget. In the past 6 months, we've recouped about $30 million in Medicaid overpayments from coordinated care organizations. Every person on the Oregon Health Plan has an up-to-date determination. We post regular reports on our website about our progress in fixing Medicaid payment issues. While OHA is more accountable and transparent, I don't want us to lose sight of why OHA exists in the first place, which is to transform health and healthcare. We're not just there to run an effective Medicaid program, though we need to do that. We're not just there to continue to transform the state hospital or to modernize public health, though those are important functions. Those things could be done and still be part of a different agency. We didn't need to create OHA as a separate agency. We didn't need to bring in the Office of Health Policy and Research. We didn't need to create a health policy board, fold in the public employees and Oregon Educators Benefits Boards. None of those things needed to be done just to effectively run operations and programs. The reason to do all of that was to create a purchasing and policy and program delivery platform that can leverage all of those investments and all of that work to transform health and care and costs across the state. So let's talk about the current state of health reform in Oregon, the challenges that threaten our gains, and the actions we need to take going forward. I want to start by looking at the state of healthcare 10 years ago and how far we've come. A decade ago, nearly 1 in 5 Oregonians, about 17%, didn't have any health insurance, including more than 1 in 10 children. 10 years ago, many Oregon families lived in fear that a serious illness or injury could wipe out their life savings or put them out of their homes. Many people depended on emergency rooms for basic medical care. And patients often navigated a complex, fragmented system without a primary care doctor to know their needs and help guide them. In 2009, 8% of the care Oregon hospitals provided was uncompensated, a relentless flow of red ink that sapped their financial strength. Many smaller hospitals across the state operated at a loss, putting these key healthcare and economic engines of rural communities at risk. 10 years ago, Medicaid costs squeezed a state budget that was already battered by the recession, forcing lawmakers to cut funds for schools, public safety, and other services. Today, we see a dramatically different picture. What changed? First, we expanded health coverage. With bipartisan support, Oregon extended health coverage to hundreds of thousands of people who were uninsured and lacked access to care. We started by expanding CHIP, the Children's Health Insurance Program, to cover children and families struggling to make ends meet. Today, 98% of children in Oregon have health insurance. Then in 2014, again with bipartisan support, Oregon expanded Medicaid coverage to adults living close to the poverty line. Today, 94% of all state residents have health coverage. The uninsured rate has dropped to 6 percentage points. That's the biggest decrease in uninsured of any state in the country. The Oregon Health Plan today covers more than 1 million Oregonians, about 1 in 4 residents in the state. At the same time, we launched coordinated care organizations and began to transform healthcare delivery. Healthcare leaders in Oregon across the political spectrum always understood that access to care isn't enough. We need to deliver better health outcomes, improve quality, and lower costs. That means transforming the ways we traditionally delivered care. Unlike other states, Oregon didn't duck that daunting and demanding task. In 2012, Governor Kitzhaber and the legislature created coordinated care organizations, CCOs. CCOs have been the engine of healthcare reform in our state. Today, 15 CCOs provide care to 900,000 Oregon Health Plan members across physical, behavioral, and dental care in their local communities. Here's what makes CCOs different from traditional managed care organizations. They're responsible for coordinated care. They connect members to primary and preventive services, help them manage chronic illnesses, and aim to provide more personalized care. They're accountable for improving healthcare quality and outcomes through financial incentives that we provide to reward performance on key measures. CCOs have the flexibility to invest in interventions that improve health but aren't traditionally Medicaid reimbursed services. And they're locally governed and accountable to their communities. We also set a goal to contain Medicaid costs to 3.4% growth over 5 years. We certified more than 600 patient-centered primary care homes, which are clinics that have to meet high standards for quality and access. We aligned health plans that cover public employees and teachers with goals of health transformation so their purchasing power could help leverage change. And then we took a big leap of faith. We bet the federal government that we could save $1.9 billion in healthcare costs over 5 years in exchange for the flexibility to make these changes and for startup funds to help get CCOs going. And on most counts, it's worked. Since Oregon launched its Medicaid reforms in 2012, our health system is doing a better job of producing better health, better care, and lower costs. Yes, we had the Cover Oregon technology meltdown, which led to the Medicaid overpayments that we've been working on fixing. But it's important to remember how far we've come and how much is at stake. Here are some of the gains Oregon's made, thanks in large part to many of you in this room. We see evidence of better health. The percentage of Oregon Health Plan members who reported being in good to excellent health has increased by about 10 percentage points. We see evidence of better care. Since we launched CCOs, avoidable emergency room use on the Oregon Health Plan has declined 50%, and Medicaid hospital readmissions dropped by 1/3. More teens received immunizations and well-care visits. Fewer adults used low-value health care, such as inappropriate imaging. And we've achieved lower costs. We helped we held costs to that 3.4% growth over 5 years, below the national average, and in so doing saved taxpayers $2.2 billion over 5 years. In direct comparison with Washington, Oregon's Medicaid reforms saved $13 per member per month. In Oregon, we reduced inpatient hospital costs by $17 per member per month, highlighting the delivery system's shift away from acute and expensive interventions. Pharmacy costs even are lower here than they are in Washington over that period of time. Through these reforms, we've kept patients satisfied. We all know big changes, especially those that are aimed at controlling costs, can come at the expense of consumer satisfaction. The good news, Oregon's reforms haven't compromised patient experience. In a recent survey, nearly 9 in 10 Oregon Health Plan members told us they were satisfied with their care. What have these changes meant for real Oregon families? Here's one story. 2 years ago, Kaleni Camacho was bedridden with obesity and poor health. Her CCO, Jackson Care Connect, enrolled her in a weight loss and wellness program at the Medford YMCA, along with her husband and son. Kaleni lost 115 pounds. Her husband lost 40 pounds and her son lost nearly 30. Kaleni no longer takes steroids or many of the other 20 medications she previously took for her debilitating conditions. The Camachos eat better, they take hikes, their lives are no longer limited by poor health. Kaleni's story shows how the unique aspects of CCOs can make a difference in a family's life by leveraging their care coordination, that flexibility, and local connections. CCOs are making their communities healthier too. In 2015, Coos and Curry counties had one of the lowest childhood immunization rates in the state. With the help of OHA, Advanced Health, the CCO in that region, started a campaign to remind parents about upcoming well-child appointments. Providers changed how they work with families and began to offer missing immunizations at every visit. Advanced Health helped members find transportation to get their kids to the appointments. As a result, immunizations jumped 14 percentage points, the largest increase in the state. But our system is far from perfect. Despite Oregon's reforms, healthcare costs in our state are still growing. We've bent the cost curve for state taxpayers, hitting 3.4%, that 3.4% growth target across the first 5 years of our Medicaid waiver, yet base costs for CCOs have risen at a much higher rate in recent years. Last year, costs grew at 6.7% across the CCO system. These increases really aren't a surprise. You don't overhaul an entire healthcare system that takes up 18% of the economy in just 5 short years, and the further you dig into the system, the harder those changes get. There are 3 drivers fueling cost increases for CCOs today. First, the risk pool has changed. As the economy has expanded and people have come off the Oregon Health Plan, those who remain tend to be sicker than those who were on the system to begin with. Pharmacy costs, as we all know, are skyrocketing. Total pharmacy costs jumped 49% in 2014 and 32% in 2015. Increases tapered to 4% last year as we've taken steps to control costs. However, pharmacy costs and expenses account for about 40% of the rate increases across all of our CCOs. And payments to hospitals and other providers continue to rise. Costs for smaller, mostly rural hospitals in the state are outpacing the 3.4% growth target. And CCOs have limited ability to control those costs. So what do these cost increases tell us? Is Oregon's 3.4% cost containment target unsustainable? My answer is yes. It is unsustainable if we continue to deliver and pay for care in the way we've traditionally done it. But I don't believe 3.4% is too low a target. I think it's too high. The reason is simple. If healthcare costs increase faster than the overall economy, healthcare will put a drag on wages and growth. Healthcare will eat away at the state budget, consuming more dollars that could go to schools, higher education, state troopers, environmental protections, parks, every other priority you can think of that make Oregon a competitive and high-quality state. Despite the aggregate cost increases at the state and national level, many CCOs have kept costs at 3.4% or less. Last year, a half dozen CCOs accomplished this feat. For example, base costs for Advanced Health CCO dropped by 4.3%. Pacific Source Central declined 1.3%. Costs for 4 others fell, stayed flat, or grew under 3.4%. These CCOs are helping prove that Oregon's capacity to transform care at the point of delivery isn't tapped out. Oregon's unique CCO model has the capability to push the brakes harder on rising costs. Health transformation is still happening in our state, and it's time to take it further. But let's be clear, costs aren't the only challenge we face in health transformation. First, our behavioral health system isn't meeting the needs of Oregonians. Too many people fall through the cracks before they can get connected to effective mental health treatment. Too many people in crisis find themselves in a jail or an emergency room. Our nationally recognized state hospital treats too many people who should be getting less intensive care closer to home. Our behavioral health system needs to deliver better access, better integration, and better outcomes. We also need to do more to address social problems that undermine good health. 80% or more of the factors that affect our health happen outside the doctor's office. Poor nutrition, substandard housing, underemployment, and lack of education don't just constrain your horizons, they stress your health. We need to go upstream and help patients long before they seek medical care. Beyond these issues, we need to confront the stark reality that our healthcare system does not serve all Oregonians equitably. On almost every health measure, including the most basic outcomes like infant mortality and life expectancy, we see intolerable and unacceptable racial, income, and geographic disparities. We need to eliminate health disparities and ensure health is in reach of every Oregonian. We're tackling these challenges in CCO 2.0. Right now, we're in the process of preparing new 5-year contracts based on a final plan just adopted yesterday by the Health Policy Board. This will be the largest procurement in state history. It'll account for more than $30 billion in state spending over the life of these contracts. As the name CCO 2.0 implies, we're not interested in incremental changes. We're not trimming around the margins. We're not responding to Oregon's biggest health challenges with technical tweaks pre-shrunk to fit our estimation of what the traffic will bear in terms of pushing the system. Instead, we see CCO 2.0 as an opportunity to reboot the entire CCO system and reinvigorate health transformation in our state. In CCO 2.0, we focused on 5 major priorities we want to embed in future CCO contracts: improve behavioral health, pay for better health outcomes, hold down costs, address social determinants of health and health equity, and ensure CCOs remain accountable to their local communities. In the past year, thousands of people told us what they wanted to see in CCO 2.0. I toured 10 cities around the state. We asked OHP members their views. Across the state, people overwhelmingly endorsed these 5 goals. Let me quickly give you an idea of how we're leveraging CCO 2.0 to respond to these challenges. I want to start with our strategy to control costs. We're going to improve cost effectiveness and efficiency. We'll strengthen financial incentives that reward CCOs for improving health outcomes and containing costs. We'll reduce the impact of inefficient, low-value care in CCO rates. We'll leverage state purchasing power to reduce costs. We'll use the weight of our $15 billion per biennium Medicaid program to align benefits and reduce costs. We'll use transparency, pooled purchasing power, and protections against the impact of high-cost drugs to help CCOs contain pharmacy costs. And we'll strengthen OHA's hand to maintain the financial stability of the system. Among other things, we'll look at multi-year rate setting to give CCOs more incentive to invest in strategies that yield long-term savings. Here's an example of how one CCO successfully contained costs despite rising drug prices and other upward pressure in the system. In 2017, Eastern Oregon CCO was able to hold base cost growth to 3.4% by using a variety of strategies aligned to the triple aim of better health, better quality, and better care. 9 in 10 EO-CCO members are enrolled in a patient-centered primary care home, and community health workers help high-risk members manage chronic conditions and solve problems in their lives that affect their health. EO-CCO invested $87 million in payments to reward providers for quality, improve dental health, and address local health priorities. The CCO uses value-based payments and shares data with hospitals and other providers to improve quality and control costs. These are the kind of strategies we want to foster consistently across all CCOs. Here's how CCO 2.0 will accelerate more payments for better outcomes and quality. Under the traditional fee-for-service model, payers like me or anyone out here who is from a commercial insurance plan reimburse providers based on the volume of visits, tests, or services patients use, no matter if the patient benefits. In contrast, value-based payments reward providers for delivering better health and quality. While this sounds a little bit esoteric, it has a real and direct impact on the lives of consumers and taxpayers. Across the state, clinics are working with CCOs to pioneer pay for performance. One example is Primary Health's contract with the Women's Health Center of Southern Oregon, which provides the clinic a global payment budget and other tools to achieve healthy birth outcomes for low-income, high-risk populations. Primary Health and the Women's Health Center started their partnership by looking at the risk factors in the lives of the women they both served. Initially, they realized that fewer than 1 in 5 high-risk women were getting the coordinated care they needed because they were so difficult to serve. The Women's Health Center retooled its clinical approach. They began screening patients for addiction, substance use, housing, and other risks. Care management payments from Primary Health enabled the clinic to employ new collaborative case management strategies. Now, 2 in 3 high-risk patients are engaged in coordinated care. The rate of low birth weight babies has dropped. The rate of unplanned pregnancies is also down. Primary Health, a very small CCO, has avoided significant costs in hospitalization, substance use treatment, and other care for newborns and mothers. In CCO 2.0, we'll encourage more of these types of value-based partnerships. We're going to set a state target for value payments and raise the bar each year until, by 2024, 70% of the spend through coordinated care organizations is in the form of a value-based payment. We'll increase CCO support for patient-centered primary care homes. We'll help clinics expand their use of performance-based payments, cover unreimbursed services, and get better outcomes for patients. And we'll help providers navigate these changes. Many providers don't have systems in place to support value-based payments. We'll offer technical support to help providers keep up with payment reforms. These changes don't just benefit members of the Oregon Health Plan, they benefit patients and payers with other insurance too. When the Women's Health Center in grants past changed care delivery to high-risk moms as a part of its value-based payment agreement with Primary Health, they changed the way they cared for every woman they saw, no matter whether she had OHP coverage or coverage from some other payer. That's how the scale of Oregon's Medicaid reforms drives practice and payment transformation across the entire system. Beyond our efforts to control costs and improve efficiency, one of our top priorities is to address the social factors that affect health. We'll reward CCO investments in social determinants. In CCO 2.0, we'll create more financial incentives to target upstream problems like poor housing, food insecurity, and lack of transportation that lead to poor health. We'll give CCOs more flexibility to solve problems before patients wind up in the doctor's office. And we'll set a statewide priority to focus CCOs particularly on housing. We're going to align priorities. In CCO 2.0, we'll require CCOs to align their health improvement plans with local public health departments and hospitals so everyone is on the same page in tackling local health problems and disparities. And finally, we'll support traditional health workers, such as community health workers, peer support specialists, and doulas, who are trusted in many underserved communities. Some people have asked, aren't these efforts an added cost burden that expands the mission of CCOs? My answer is this work is already happening because CCOs already recognize the health benefits and cost savings they can achieve by tackling social problems that impair member health. For example, in Jackson County, All Care and Jackson Care Connect both partner with Rogue Retreat, which provides affordable housing and case management to homeless individuals and families. CCOs help cover case management services and help members maintain short-term housing and prepare for renting or owning a home in the future. An all-care evaluation found this partnership produced a 60% reduction in median per member per month spending. The CCOs don't need to go out and build housing, but there's plenty they can do to maintain that connection to someone's ability to maintain their housing. Around the state, other CCOs have partnered with other nonprofits to help members stay out of hospitals and homeless shelters, eat regular healthy meals, connect kids to school, and improve access to safe transportation. CCOs are not doing the work of food banks, housing agencies, or other nonprofits. They're leveraging the power of those local partners to help members in parts of their daily lives that have a direct impact on health. In CCO 2.0, we want to encourage more of these effective partnerships. Throughout the CCO 2.0 input process, the top priority among all stakeholders was to improve behavioral health and streamline access to care for consumers. This is also Governor Brown's top priority. In CCO 2.0, we want to remove barriers between behavioral and physical health so all patients can receive the right care in the right place at the right time. We need to improve care coordination by requiring CCOs to be fully accountable for the behavioral health benefit and promote warm handoffs between medical and behavioral health providers. We'll help more behavioral health clinics offer primary care on site. We'll also expand access to care. We'll set standards that encourage CCOs to expand provider networks, and we'll encourage CCOs to expand services in rural and other underserved areas, while we also expand services for children. We expect CCOs also to develop a diverse and culturally responsive behavioral health workforce. The goal of better integration and coordination is already happening in some CCOs and some practices. Here's a story that illustrates what we're trying to achieve across the system. 2 years ago, an Oregon man in his mid-30s called his mother to say goodbye. He planned to drive his car off a cliff and end his life. Understandably, she panicked. She called 911, and her son ended up in the emergency department at a local hospital. She made another call to her own family physician, which was a practice in the southern Willamette Valley, which was part of Trillium, her CCO. They saw her son the next day and got him enrolled on the Oregon Health Plan. A physician talked with the man about his depression and suicidal thoughts, then did a warm handoff to a behavioral health counselor in the same office. The counselor pulled in a psychiatrist. Today, the man is running his own business. He's stable, happier, and doing much better, in large part because his clinic didn't let him fall through the cracks in this moment of crisis. In CCO 2.0, we want stories like this to become a common best practice, not an unusual bright spot. Finally, we're also taking steps to ensure CCOs are transparent and accountable to local communities, such as including community representation and OHB members on their boards. Any new CCO entrant into the market will need to have a pre-existing Oregon footprint in the Medicaid space. We're developing rules to ensure large amounts of Oregon's Medicaid dollars aren't funneled to out-of-state shareholders. As we look forward to 2019, there are big questions looming over healthcare in Oregon. The first is Oregon's ongoing epidemic of substance use. Earlier this year, Governor Brown declared substance use and addiction to be a public health crisis. Oregon continues to rank at the top of the list among states for illicit drug use, opioid overdoses, and deaths. With the help of many of you, we're confronting this crisis in 3 ways. We're improving pain management by expanding Medicaid benefits to cover safer and effective non-pharmaceutical pain relief treatments, such as acupuncture and physical therapy. We're reducing harms to patients on opioids. We've expanded addiction treatment, especially in rural areas. We're putting naloxone into the hands of high-risk patients, first responders, and Good Samaritans to prevent overdose deaths. We're reducing overprescribing and the number of pills in circulation. We've worked with physicians to change prescription guidelines and strengthen the prescription drug management program, which tracks pills dispensed to patients. The strategy, I'm pleased to say, is working. In 2016, deaths from prescription opioids dropped 17 percentage points, the steepest decline of any state in the nation. Yes, that's worth a round of applause. In 2019, we'll work with CCOs to reduce the number of people exposed to risky doses of opioids for short-term acute pain, such as a broken ankle. We'll expand substance use treatment and give more people access to medication-assisted treatment and peer support. We'll help doctors better address the complex needs of chronic pain patients. The second challenge is the need to modernize public health. For more than a century, our public health system has protected us from disease outbreaks. It provided health care and nutrition assistance to vulnerable women and children. It's helped us all live longer, healthier lives. Yet even today, only 1 in 3 Oregonians live in a community that has a full range of public health services. Beyond this inequity, times are different. Our public health system needs to adapt to a world in which dangerous new diseases are a plane flight away. Our climate is changing. Environmental hazards like wildfire smoke and, yes, that toxic algae have become the new norm. And local communities need more help than ever tackling health disparities and preparing for emergencies. This year, legislative support enabled OHA to provide $5 million to help local partnerships prevent disease outbreaks, increase vaccinations, and prepare for disasters. In 2019, we're going to build on those efforts to promote better on-the-ground collaborations to make sure more Oregonians have vital public health protections in place in their towns and cities. The third and most pressing challenge is a budget shortfall that threatens to undo the coverage gains and system reforms we've achieved in Oregon. Next biennium, the state faces an $830 million gap in its healthcare budget. The gap is the product of reduced federal funding, caseload changes, and the expiration of one-time funds, including the expiration of temporary assessments voters approved earlier this year with the passage of Measure 101. Without a budget solution, we'll have to look at cuts to coverage, benefits, and provider rates in the Oregon Health Plan. Oregon would risk losing health coverage for more than 300,000 people. We'd jeopardize $5 billion in federal investment and put tens of thousands of healthcare jobs at risk across the state. The good news is there's a strong consensus across the spectrum to maintain health coverage. Policymakers and the public understand Oregon can't afford to go back to the healthcare system we had a decade ago. Consumers, employers, and providers want permanent, sustainable funding solutions that avert these 2-year cycles of political acrimony, uncertainty, and patient anxiety. The question is, how will we fill the shortfall? Governor Brown's health advisor, Tina Edlund, has convened healthcare and business leaders across the state to find a solution. Options including finding cost savings, continuing current provider assessments, asking self-insured plans and employers to put more skin in the game, and other factors. No decisions have been made yet, but based on these discussions, I'm confident the governor will offer an answer in her budget that will be fair, enjoy broad support, and put healthcare funding on a firm footing for the future. So let me wrap up by sharing this thought. At OHA, I often tell our employees that my job is to help them do their job. In turn, for all of us at OHA, it's our job to help you do yours. And all of us together are united in the task of transforming healthcare in Oregon. We've collectively built a healthcare system that makes the lives of Oregonians measurably better than it did a decade ago. We've earned our national reputation for innovation, but we're not finished. The next phase of health transformation in our state won't get any easier. At OHA, we're committed to being a transparent and accountable partner as we all work on writing the next chapter of health transformation in Oregon. I'm confident that by working together, we can meet Oregon's healthcare challenges, improve outcomes, and continue to bend the cost curve for the people of our state. Thank you.
So let's talk about behavioral health first. You and I did a podcast interview here a couple months ago, and you had said at the time that, you're still kind of, these are my words, but you're kind of feeling your way through that process to kind of re-elevate the behavioral health topic and the position for improved line of sight at OHA. How has that gone in the last few months, and how are you feeling about getting more of a window into the performance of behavioral health in the CCO system?
Sure, so a couple of things about that. Several years ago, the agency, in an effort to try to walk its talk in terms of integrating behavioral health and physical health, effectively disbanded what was our old addictions and mental health division and put the functions that were there in alignment with physical health wherever they lived in the organization. And in retrospect, I think one of the things that is challenging about that is it made behavioral health disappear in the agency. Mm-hmm. You couldn't find it as a programmatic area, you couldn't figure out who was in charge, those kinds of things. So effective July 1st, we reorganized, not quite the exact structure we had before, but a similar one where we reconsolidate those behavioral health programs into a single area as part of our health systems division together with Medicaid, so we could foster connections between those two. We're in hopefully the last stages of hiring a behavioral health director who will be responsible for running that program, and so I'm really encouraged just about those structural changes. I think the phrase that I used at the time is I started this job knowing nothing about behavioral health, and after a year now I know next to nothing about behavioral health. But I think I've learned a little bit, and I think I've first of all got a better grasp of the problems. And there's all kinds there's lots of bodies of work out there that talk about what the challenges are around poor access to services, the wrong kinds of services in the wrong place, bad handoffs, a complex funding system, too much complexity for patients or families to understand. And I think even better, I have an understanding that there are certain circumstances when someone is at a mental health crisis or a substance use crisis where they've gotten to the point where they say, I'm ready to seek treatment. Mm-hmm. And we got to provide that treatment now. Yeah. When they reach that moment in our system, and this isn't just in the Oregon Health Fund, this is across behavioral health across the state, doesn't do a good job of meeting those needs now. And so we're working with some projects in the Portland metro area and elsewhere to try to begin to see if there are short-term steps that we can take to try to address those critical gaps in the system and then broaden that work for more broadly.
And so as you, again, feel free to throw up your hand and I'll try and grab you, but as you, Pat, think about, and the OHA thinks about this next procurement, you have talked before about being open to any healthcare entity, any healthcare entity with a footprint in Oregon can bid on this next CCO procurement. Is that still the thinking? and you mentioned trying to mitigate against dollars flowing out of state as a result of shareholder dividends or profits. Tell us the latest there.
A couple of things about that. I've been quoted as saying more things than you can imagine about this topic around the state.
I heard you quoted that you love all out-of-state providers, all out-of-state health plans. I'm just kidding.
Right. Yeah. OHA is agnostic as to the question of is there some right number of CCOs. CCOs are inherently a community organized, community governed function, and so how many is the right number is really up to the community. We've outlined the notion that to be a proposer in our request for applications, you need to have some kind of a footprint in Oregon, and I'm sure at some point we'll come up with some 3-page long definition of what that means, but the real simple version is you either are accepting risk in some fashion in Medicaid today, or you have a certificate of insurance through DCBS. Mm-hmm. That's a reasonably broad net, but it's not all comers. Mm-hmm. So that's what we're trying to shoot for in terms of who can apply. In terms of profits, two things. The legislature took one action and declined to take another action that bear on this. The first is that they require that CCOs that have, I'll use the word profits, that's not quite the right term if you're a nonprofit, but gains over expenses, a portion of those need to be devoted to social determinants of health, and so we're implementing that regulation today. They also looked at the issue of was it okay to have for-profit CCOs or should they be required to be nonprofit, and they declined to take that action. Mm-hmm. I'm not going to try to step in and take that action for them, but what we want to do is make sure that the gains that are achieved in the system can do both, basically, be reinvested in the community and reward shareholders if that's the structure. And we're going to try to put some shape around that.
So let's talk about financing for a second. On the one hand, 3.4% is now a long established number, at least going back to 2012. You talked about today that it should be lower, that 3.4 is not excessive, but that it's higher than it should be. A lot of CCOs would argue that, whether 3.4 is the right number or not, you can't fix the top line number of a health plan without fixing or mitigating upward pressure of consolidated providers like hospitals, especially pharma. In other words, if you fix the top, you got to provide some tool to put downward pressure on these input prices also. What are your thoughts on that? Do you think that in order over time to be sustainable, that Oregon policymakers are going to have to figure out a way to regulate the upward pressure of the component parts of the healthcare system?
In the 5.5 minutes we have remaining, there are some components to that. Start with pharma, which is the biggest, most glaring problem, which will be very, very difficult for us to solve without federal help, either in the form of some kind of a change in federal law. The biggest driver, if you don't know in pharma, is that if a drug is approved by the FDA and then negotiates with CMS a rebate contract, we are required by law to make that drug available to any OHP member for whom it's medically indicated. With the 21st Century Cures Act, FDA approval ain't what it used to be. And what we're seeing is the emergence of drugs that are very expensive and often have a less well-established track record of value to patients. And it's very difficult for us to try to control those kinds of costs at the local level. Mm-hmm. We were really hopeful that Massachusetts would be successful in trying to waive out of the rebate program to be able to manage those, and they weren't. So there's that element. The other elements, I think we're actually getting pretty good traction around controlling on hospital costs. This is way in the rate setting weeds, but we basically did kind of a rebaselining of hospital costs to set them at an intended rate of percentage of Medicare, which for the larger hospitals in the state was a pretty significant hit in their cost structure, and so we were able to put some downward pressure on that. Small rural hospitals are a little bit of a different animal because they've got a rate structure that's guaranteed to cover costs, and that's harder to maintain. But I mean, EOCCO was able to maintain its costs at 3.4%, despite being virtually entirely served by those small A and B hospitals. So I think when you get outside pharma, we've got adequate tools to be able to continue to manage costs. And that's to say nothing of starting at the population level, the partnership between CCOs, public health, and others to drive down population factors that drive healthcare costs again before anybody ever shows up at a doctor's office.
You mentioned, I noticed EO, CCO a number of times. I thought that was probably really good stakeholdering on their part, talking to you. Now that you've had some time in this position, as you look at the various CCOs and as they come and talk to you about the work that they're doing, what do you believe, just in that sort of kind of narrow experience, what do you think makes a good CCO partner to the state, a good CCO partner to the community? What are some of the elements, not naming names, but some of the elements that go into a successful high-quality CCO model?
Well, I think partner is really the key word. It's a fine line that we have to manage between OHA and CCOs of partners in trying to advance healthcare transformation and contractors, right? And I think the trap you get into is if we see each other in 100% in one camp or the other, we're probably not going to get good outcomes. We can't not think of them as contractors, but we can't only think of them as contractors. I think when I look across CCOs, I see sort of the same thing. If they look at their provider network and other entities in their community, if they think of them as partners and not just providers, those seem to be the places where there's more traction for more creativity and more aggressive work to try to improve health and drive down cost.
Yeah. Well, I got to tell you, I think Oregonians and the healthcare sector take a lot of pride in the CCO model. They, I think, appreciate, as I said, the steady hand that you have brought to this position. The country is watching and hopeful that CCO 2.0 will continue to be a success. Thank you for being here all day, for your time today, and appreciate your leadership. Pat Allen, Director of the Oregon Health Authority. Let's give him a round of applause.